Good morning, good afternoon, or good evening to all our participants today. My name is Fred Apple. I will be moderating the session today, which I think you will enjoy tremendously. Uh, the speakers that we have talking today. Uh, I personally am sitting here in Pienza, Italy, on the way to the IFCC meeting in Rome. Our speakers today, Professor Yadar Sandoval, is in the US. He will be discussing what is current evidence for the safe single sample rollout of non-STEMI. Professor Nick Mills is in Scotland. He is going to present myocardial infarction rule out, so what? Follow-up and evaluation of long-term risk. And Professor Collinson, Paul, in the UK in London, will be finalizing his talk, sample the implementation of rule out and rule in algorithms. What should the laboratory do? The way we're going to run the meeting today, the one I will moderate, is that at the end of all three presentations, we will take questions and have answers from the entire panel. But I'll just have a couple of introductory slides. I always go back to the fourth universal definition of myocardial infarction, because I think it was the first time in the global world of cardiac biomarkers we defined the term myocardial injury. And the talks today will key on this term myocardial injury in two reasons, because we're going to look at early assessment for possible rule out and possible high predictive value of ruling in. And when I look back and I summarize what are the most important contributions for implementing high sensitivity cardiac troponins, whether it's I or T in the clinical practice, the number one thing I have to point out is the concept of improved analytics. And I'm not going to go into detail. Most of you know that, but it's really the improved analytics which really has changed the world of this cardiac biomarker to be a large player in a lot of different areas. We talked about detecting early myocardial injury. The focus today will be on early triage and discharge, and risk assessment will be touched upon. Now, this is a knockoff slide that I first saw the concept from Professor Mills, and I circled one of the four areas that we're going to discuss heavily today, the one in green, which is low risk. And we all have to keep in mind, we're not talking about diagnosis here today. That's in the red circle. The red circle looks at the diagnosis of MI, where we're looking at the 99th percentile upper reference limits by sex specific. But we're going to go below the 99th percentile now, and our speakers will talk and discuss the role of looking at a different threshold, either as a single sample or possibly they might show some data on a 0.1 or 0.2 hour delta change that'll provide a very high negative predictive value, as I show here, 99.5%, and a concordant possible sensitivity of 90% or the equivalent. There are many assays that are cleared around the world. This is my rendition of the clearance that I picked up, either CE Mark, CE China FDA, or the US FDA clearance of many cardiac troponin I and T assays in the marketplace. And as I put here in red in the bottom, if you don't know, not all assays are created equal. The assay thresholds that we're going to hear today, there may be some commonality to the absolute concentration in whole numbers measuring nanograms per liter, but important to understand that numbers could vary because of a lack of standardization, lack of harmonization, which will not be likely, in my view, in our lifetime. But will listen. So the important thing is you need to understand your own assay, and you need to rely on your own data or other data where these assay thresholds have been both derived and validated for each individual assay. And one of the last slides I show here as an introduction is the components we have to consider when we're thinking of troponin release, which we're starting to look at now for early disposition of patients on presentation. And never lose track of the thought that troponin is not a standalone marker. It's only part of the clinical equation, which our clinical colleagues, with Nick, Paul, and Yadar being clinical colleagues, need to assess as components when they're making clinical decisions. And the one thing I'm going to show you a very old slide, since we're talking about single samples, and I'm looking towards the future. This was some early work on a serum electrophoretic pattern on a patient over an evolving myocardial infarction, Jennifer Van Eyck. And where I think the future might assist us as we're thinking about early rule out and assisting with the timing of an injury or infarction. And the beauty of this slide looks actually at patterns of changing forms of cardiac. This happened to be cardiac troponin I. You can see both samples in these two different patients measured 5.8 nanograms per mil. But clearly the panel on the left is a early injury that hasn't had chances to degrade, to be phosphorylated, to see end and terminal degradation. While the panel on the right is an older infarct, even though it's only 12 hours old, you can see the multiple forms that are being detected. And as we all know and are learning to know, the antibodies used by each manufacturer pick up different forms of TIC complex, IC complex, and different fragments and forms of all the troponins. So that's why we need to know the assay we're using. So enough of my introduction. I am honored to introduce, and I'll let the speakers do more of an introduction if they like, a colleague of mine, Professor Yader Sandoval. He trained at my hospital at Hennepin County Medical Center as an internal medicine resident. I've been fortunate to have known Yader for many years. He did research with me over his training as a resident, and for the 3-4 years, he got specialty fellowship training in interventional cardiology. He spent time at the Mayo Clinic, and presently he's back in Minneapolis, working at the Interventional Minneapolis Heart Institute at Abbott Northwestern Hospital. So if I just here, I'm going to stop sharing and I'll let Yader go ahead, Yader, and feel free to load your slides.
Thank you, Fred. Give me a second here to share. All right, is the full screen visible?
Make sure you click the full screen.
Okay. All right, I think we're in the full screen here. Well, thank you for the introduction, Fred. It's really a pleasure here to be part of this IFCC webinar on single sample rule out. And I've been tasked to discuss what is the current evidence for safe single sample rule out of non-ST elevation myocardial infarction. And as mentioned before, I'm a cardiologist, and I look at this, heavily from the clinical aspect of the how can we integrate and implement this safely to really expedite the evaluation of these patients in a safely manner. These are my disclosures. So the title of the webinar is, again, single sample rule out of NSTEMI. Are we ready for prime time? And I'll break it to you is that absolutely yes. And I'll tell you why. This is not a dilemma or really a debate at this particular point, I would say, in 2023. This is the past using contemporary assays. This is an old classic paper from Keller, New England Journal of Medicine, 2009. And if you look at the contemporary assays here, an INT assay that Keller evaluated, both the sensitivity and the negative predictive value, even pushing the symptom onset to less than 12 hours, were really suboptimal. As you can see there, sensitivities of 88, 64%, really not at all acceptable and safe for single sample rule out using contemporary assays. That has totally changed over the past recent years. And the fact of the matter is that the major clinical practice guidelines, such as the European Society of Cardiology and American guidelines, are already endorsing single sample rule out. These are the European Society of Cardiology. And as you can see here, since the 2015 iteration and subsequently in the 2020 ESC guidelines, they've had class 1 recommendations that incorporate single sample rule out within the 0-1 or the 0-2 hour algorithms. These algorithms, as you may very well be familiar, endorse and allow that if you have a very low baseline concentration at presentation with a symptom onset of more than 3 hours, and often this very low baseline is often refers to the limit of detection, that you are eligible for pretty much to be ruled out for acute myocardial infarction. And again, I want to emphasize this has been recommended in Europe as class 1 recommendation pretty much for the past 8 years, and it will be interested in doing the discussion to learn from some of our European colleagues as to how much this has been actually adopted into clinical practice. This is again from those ESC guidelines. This is the 0102 algorithm that conceptually is the same approach, that if you have a very low sample presentation as shown here in the upper left, and those concentrations are tabulated in this document and often correspond to the limit of detection for some, but not all of these assays, it would imply that you are directly eligible for rule out, as long as, of course, you don't have an ischemic EKG and you have more than 3 hours from symptom onset. Finally, after many years of waiting in the United States, we eventually got the high sensitivity assays FDA cleared in 2017, and just in 2021, major groups from the different societies, cardiology, emergency medicine, came together and finally provided a recommendation for this assays as well. In our guidelines in the United States, for uncertain reasons, and we actually criticized this in a document that we published jointly in circulation, but nevertheless, a recommendation, there's a 2A recommendation that, as pointed out here, mentions that for patients with acute chest pain, a normal ECG, and symptoms suggestive of ACS that had symptoms for at least 3 hours before emergency department arrival, that a single high sensitivity cardiac troponin concentration below the limit of detection is reasonable to exclude myocardial injury. So similar recommendations as those from Europe, and we'll talk about some important caveats from this recommendation that is available in the United States. When we think about single sample rule out, and at least this is how I have come to pretty much sort of categorize these concepts, is that we're thinking about either analytical or optimized risk certification thresholds. Pretty much the field of single sample rule out started with analytical thresholds, and Nick and others have really pushed the field to challenge whether we can use optimized risk certification thresholds to really optimize the efficacy of these approaches. But if we're talking about analytical, it's pretty much using thresholds such as the limit of detection, which is the lowest detectable cardiac troponin concentration reliably distinguished from the limit of blank in a sample containing low cardiac troponin concentration, or the limit of quantitation that is often defined as a 20% total imprecision. If you use either of these thresholds, it is often deemed that they are associated, as pointed out here in the blue line, with a very high negative predictive value and sensitivity. On the other hand, other groups, and Nick and his group have really pioneered this field, have suggested that maybe we can use higher concentrations that are optimized to really still provide a very high negative predictive value, and capture more patients that are eligible for the single sample rule out risk certification approach. So again, think about those two approaches: analytical or optimized risk certification thresholds. Historically, this started, we can debate about this, but at least to my understanding, the first paper that really looked at this and published it in the peer-reviewed literature was the APACE group in their classic paper by Reichling in 2009, in which they looked at numerous both sensitive and high sensitivity assays. And when they looked at the high sensitivity cardiac troponin T assay, as you can see here with the T assay from Roche, they had an 100% sensitivity and an 100 negative predictive value. This was a modest study of 718 emergency department patients. And at the time, this already provided the signal that maybe at the low end, as compared to these other assays, the high sensitivity assays could unlock a novel opportunity to identify low-risk patients with a single sample. This observation led to the first dedicated study to look at this in detail, which was by Rick Body, previous member of this committee, who in collaboration with other colleagues such as Alan Jaffe and others, looked also at the T-assay to specifically evaluate this particular issue. In this particular study, they evaluated the limit of blank of 3 nanograms per liter with the Roche assay. And again, they observed among 703 patients with chest discomfort that 195 had values below 3 nanograms per liter, which corresponded to about 28% of patients, and none of these patients had an acute myocardial infarction, with an excellent sensitivity and negative predictive value. And this started building the case that this was a very promising approach. Why does this work conceptually? Well, why this works because pretty much there is a continuum at both ends. The higher the concentration, not surprisingly, the higher your troponin is, the higher your risk for acute myocardial infarction and adverse cardiovascular outcomes. Whereas on the other hand, the lower the concentration, the lower the risk for myocardial infarction and adverse cardiovascular outcomes, and the higher the sensitivity and the negative predictive value. And the question is finding that thresholds that you are comfortable with, that is acceptable and safe for your healthcare environment. What are other reasons why this works? Well, the other reasons why this works, and we've learned this now across numerous studies, is that high sensitivity cardiac troponin concentrations are pretty much a good barometer and measure of cardiovascular health. This is one study from Rubin looking at determinants of high sensitivity cardiac troponin T in the general population. There are numerous other studies that could be shared. I'm showing this particular one, that as you can see, associated cardiac troponin concentrations across the continuum with systolic blood pressure, glucose, body mass index, NT-proBNP, and pretty much the lower the concentration, the lower the likelihood for having such abnormalities and comorbidities. So again, therefore, these concentrations at the very low end become a very objective metric to find patients that are healthier. This has been also associated with cardiovascular outcomes specifically, as well as mortality. This is from Martin Fan, John Pickering, one of the longest follow-up cohorts looking at the low end. If I recall correctly, this looked up to 5 years. And as you can see here, at the low end, likewise, if your concentrations are low, very low hazard for mortality, as well as for major adverse cardiovascular events, and illustrating how, even though we like to use thresholds practically to inform patient care, pretty much these concentrations are a continuum across the board. The lower the better, the higher the worse. We could discuss at length the numerous studies in this field now following almost a decade of a number of these studies. As you can see here, many of these studies go back to 2011 and so on. There's been now meta-analysis that have looked. This is one, for example, for the T-assay that has really tabulated a number over 10,000 patients, 11 cohort studies. And the approach has been, I think, pretty much well validated that at the limit of detection, particularly with a non-ischemic ECG, has an excellent negative predictive value and sensitivity. And again, this is the reason this is now endorsed in clinical practice guidelines. So that introduction really focused, as mentioned before, on analytical thresholds on that limit of detection, particularly. The first group to really challenge this approach and say and ask, is there a better way? Was one of our next speakers and a colleague and friend, Nick Mills and Noob Shah, who really said, well, sure, the limit of detection works well, but what if we can really optimize that to find more patients that are eligible for this approach? And this is the classic now figure illustration from this paper showing how, for example, for this particular assay, this is the Abbott high sensitivity assay, that the limit of detection is around 2, as pointed out here. Certainly, consistent, the negative predictive value is very high at this end, validating that the analytical thresholds works very well. But as you can see, if you go higher to less than 5 nanograms per liter, the negative predictive values are still very good. And that suggests that therefore you can capture more patients and make this more valuable as a clinical approach. This was the high stakes approach, and I'll discuss about that later. This has also been evaluated now and confirmed to be a valuable approach with other assays. This is our validation in the high US trial across 29 United States sites, now looking at the Siemens assay, and similarly showing that if you go above the limit of detection in this particular assay, less than 5 nanograms per liter, consistent with a high stakes approach, this also worked very well in identifying, as in this particular study, 50% of patients is low risk, with also a very low risk of myocardial infarction and adverse cardiovascular outcomes up to 30 days. So again, showing how this optimized risk stratification approach is very valuable. The reason I mentioned before that it's interesting that the United States guidelines provided just a class 2A recommendation, and we can discuss this subsequently during the Q&A session, is why was it only a class 2 recommendation provided? Arguably, maybe some of these trials might not have been available at the time when this was a particular level of recommendation was provided. But at this particular point, we have 3 randomized trials that have looked now at the single sample rule out incorporated within these trials. You think about a lot of things in medicine, even a lot of things in cardiac biomarkers, and ask yourself, is there a randomized trial that endorses what I'm doing? And often you will find that that's not available. But in this particular field, we have now 3 multi-center international large trials that have confirmed that this approach is very safe. High stakes looked at the AVID assay, 7 sites, large, huge trial, over 30,000 patients. They used at the optimized risk stratification threshold of less than 5 that I already mentioned before. And as you can see, only 0.3% of the patients that were eligible had a myocardial death up to 30 days. Very safe approach. Did not meet the endpoint, but I think it confirmed that safety was a very, very, very safe approach. Rapid TNT, it looked at the 0-1 hour protocol. This looked at the limit of detection for the assay as part of the 0-1 algorithm, and it showed that as part of that algorithm, it also had an excellent negative predictive value for 30 days. And Loaded was in a specific trial looking at the limited detection of various assays, Roche, Abbott, Beckman. No patient with an undetectable high sensitivity cardiac troponin value had MACE within 30 days. This is some more details of each of the assays. As mentioned, this is rapid TNT, in which they compared the 0-1 hour algorithm to the standard of care, and the 0-1 was not inferior to met their non-inferiority endpoint as compared to the standard of care. And what I want to emphasize with respect to the single sample rule is that it had an excellent negative predictive value as part of that algorithm. This is Loaded that I already mentioned. This trial did not meet its primary outcome, which was looking at patients discharged within 4 hours without MACE at 30 days, as shown over here on the right. However, it did confirm, as mentioned, that no patient with undetectable concentrations had adverse outcomes. This was a more modest study, 629 patients. And as I already mentioned, the large historic trial really showed that an early rule-out pathway using optimized risk stratification thresholds reduced length of stay and was very safe, as mentioned before. So critically, to really underscore that now we have multiple trials. What has been the challenge for us in the United States? The challenge is that even though there's a lot of data for the limit of detection, for example, the limit of detection was not cleared for clinical use in the United States. Assays were cleared to report as low as the limit of quantitation, which is a 20% coefficient of variation. And therefore, we were left with the question is like, can we use such concentrations or do we need more data? Unless you are able to use some of the optimized risk stratification thresholds that we discussed before. And again, this has been a challenge for those of us that are using assays in which there is less data with optimized risk stratification thresholds, in which one has been left with the question of, is the limited quantitation safe, since there's just limited observational data? And again, this is the lowest reportable concentration per the FDA as compared to the limited quantitation concentration of detection that is available in Europe. For that reason, we led the largest study to date on this particular field. We looked at over 85,000 patients across the Mayo Clinic healthcare system, looking at 22 sites, part of the Mayo healthcare system, in collaboration with our colleague, Professor Alan Jaffe. And as you can see, if you look at the limited quantitation, which is the lowest threshold that you can report with this particular assay, for example, in the United States, this allows us to identify about 29% of patients in the overall cohort, about 40% or so in those with chest pain. And importantly, also at this threshold, at the limited quantitation, very low risk of acute myocardial injury, as shown here, our index presentation. And if you look at safety, 30-day death or MI in an adjudicated cohort, well under 1% risk of adverse events. So also confirming that this is a very safe approach, similar to the limit of detection and the optimized thresholds, albeit without the randomized trials and data that some of the other studies have. As we wrap up here, and I know that one of the other speakers will be discussing on this in more detail in the code ACS, but as we look forward into the future, there's a lot of interest in how do we even potentially improve these approaches, potentially with artificial intelligence and machine learning. This was one particular approach from our colleagues from Hamburg, Johannes Newman, the Artemis study that was recently published, looking at a diagnostic model using a single high-sensitivity cardiac troponin measurement with various assays. And here, as you can see, it integrates a number of variables within this AI models, such as symptom onset, age, sex, heart rate, hypertension, and so on, as shown here. And it can identify, it can push the proportion of patients eligible higher than the analytical approach can do alone. And this is something that one of the subsequent speakers will elaborate further. But it's as we look into the future, I think this is something that we can really aspire to evaluate further. The question is, of course, can we generate the wealth and strength of data that we have with the present analytical and optimized recertification approaches? The other future direction is the issue of making this more practical, and maybe using point-of-care assays to really shorten the time from all this nice figure from Andrew Chapman, that you get the venous sample, you have to transport the sample to the lab, you need to wait, the analysis on the platform, verification, and now result. What if a point-of-care were available that could unlock the same approach? Our moderator, Professor Fred Apple, was the first one to look at this in a large study just published recently in Circulation, collaboration with Professor Cohen and a number of us, and looking at the Atelica point-of-care high sensitivity assay and showing how this is appears to be very also effective approach with point-of-care assays. We need more data similar to what we've done already with laboratory instruments, but very promising that this may be a potential approach that will really unlock this to different healthcare setups. As I wrap up here with my time, this is how we've done this at our center. We do endorse the single sample rule out at the limited quantitation of less than 6. We emphasize that patients must have symptom onset more than 3 hours, and we also underscore that they must have a non-ischemic ECG. So my take-home point is that a single sample, from my perspective, it's an established strategy to identify patients at low risk for acute MI. It is supported by multiple observational studies, meta-analysis, and randomized controlled trials. And it should be considered in low-risk patients more than 3 hours from symptom onset with a non-ischemic ECG. There are still some questions that we can discuss during the Q&A, such as sex-specific differences, the emergent data on point-of-care assays, and whether we're prime time for that. I think it's a fair question. And how can we improve the efficacy to these approaches, for example, using artificial intelligence, and whether some of the windows of early presenters can be shortened. Some people talk about 2 hours, 3 hours. Can we potentially shorten that window? But the reality is that there's a lot of data for rule out, and this is really prime time. And arguably what we need more is a rule in. With that, I will wrap up, and thank you so much.
Yader, thank you very much. If you could remove your slides, then I'll have Nick add his now, would be great. Awesome presentation, Yader. Nick, you go ahead, and if you want to load your slides. Our next presenter is Professor Nick Mills. He's a cardiologist at the University of Edinburgh. At first, I must say that all the speakers today, I was remiss in not noting this up front, are part of the IFCC Committee on the Clinical Application of Cardiac Biomarkers. We're all members or consultants under the leadership of Professor Kristen Acker from the University of Bergen up in Norway. And that said, Nick is going to talk today about, Nick was, I should say, one of the early people in this field that looked at single sample markers. He, out of Scotland, had a unique opportunity to, I guess we'd say, harmonize a country. And on that note, Nick, I'll let you take over. Thank you.
Thank you, Fred. Yes, it was an interesting experience trying to get everyone to do the same thing at the same time. So that was an amazing overview of the literature there from Yader. I'm going to focus on a narrower question, which is what we do after we've ruled out, and talk a little bit about some emerging data on strategies that we might consider recommending alongside cardiac troponin. Just by way of declaration, our research is funded by the British Heart Foundation, but I've worked with multiple diagnostics companies on the guidance around the use of their tests. But our goal ultimately is to work out how we can use these tests as effectively as possible to guide clinical practice. So I'm going to start just by highlighting one statistic. So although everyone knows chest pain is really common, in the UK we have around 1 million presentations to the emergency department with chest pain a year. I have no idea what that translates to in the US, but a lot. 9 out of 10 patients don't have a heart attack. And while we've got great evidence to manage those who do have the condition, we are limited a little in our evidence base for those who do not have a heart attack. And yet this costs our healthcare system vast amounts of money each year. Some of it may not be well spent. So the focus for this talk is how we identify those patients who do not have myocardial infarction, who might benefit from some further investigation or follow-up. When we moved from contemporary to high sensitivity troponin, we had the opportunity to use troponin differently. Instead of using a single threshold, as we've heard, just to rule in and rule out the diagnosis, we now have much more granular information about cardiac troponin in all comers that we're starting to use as part of our day-to-day practice, not just to make a diagnosis and decide who comes into hospital, but to guide subsequent risk. And the pathways you've heard about can be divided, I think, into two broad groups. Those that attempt to rule out rapidly using a single measurement, a little like the pathway we use here in Edinburgh, and those that try and do a little more by using both rule in and rule out thresholds and serial testing. But there is a commonality and a common thing to both of these approaches, and that is that there is inevitably a group of patients identified who have intermediate troponin values, and they may merit particular attention when it comes to looking at subsequent risk and investigations. And so here's some data from our first experience with the high sensitivity assay as part of the original high stakes trial, where we took the 32,000 patients who had troponin values within the normal reference range, and we reported their outcomes in terms of risk of myocardial infarction or cardiac death at 1 year. And it was pretty clear that those with intermediate values were substantially higher risk than those with values below the rule-out threshold or limit of detection. In fact, that risk was 5 to 10-fold higher. So it's a very simple risk stratification tool, and those without myocardial infarction, troponin in itself is giving us some guidance as to who we might focus our attention on. Yader mentioned this randomized trial, but I want to share with you a little bit of work that we're doing currently to try and tease out what this means for patient care. So although when we introduced a single test rule-out pathway, the major benefit was getting more people home. We increased the proportion discharged from 50% to 75%, and the majority of that was due to getting more people with very low values on the left-hand side here home from the emergency department, with a slightly smaller impact on those that were intermediate probability, but we still sent more home directly. We started to look at the impact that had on subsequent events, and this is just the 1-year data, but we have 5-year data to come. And I think what it shows you once again is that those with values below 5, who are low risk in the middle, have good outcomes out to 1 year. For those who are intermediate risk, the outcomes are worse with a 5% event rate at 1 year. But you can see that after deploying the early rule-out pathway, the risk was lower overall, and that was driven particularly by a reduction in subsequent myocardial infarction or cardiac death in those with intermediate troponin concentrations, suggesting that this approach to risk stratification is not only safe, but may actually help us identify those that need further investigation and treatment. This, for me, is a particularly important analysis given some of the data that was published from the rapid TNT experience of introducing the 0-1 hour pathway, where the group that were discharged earlier with intermediate troponin concentrations actually had a worse outcome at 1 year. Although it was non-inferior at 30 days, there were more events in those that were discharged using the 0-1 hour pathway than those that were managed using a more conventional approach. And the authors speculate a little in this report that it may have been down to fewer tests performed and follow-up appointments arranged in those that were discharged directly. So it is really important that we get this part of our pathway right. And before I talk a little bit about an approach that we might consider, I just want to highlight a couple of things from the guidelines that you've already heard a little bit about. So there are some excellent guidelines in this space. The Universal Definition of Myocardial Infarction, the NICE guidelines, they give us guidance on the use of troponin, but they do not serve as practice guidelines and give us guidance on what testing and follow-up to arrange in those without myocardial infarction. However, the ESC 2020 guidelines do, and I just draw your attention to this one figure. They recommend that those with very low troponin concentrations could be discharged with optional stress testing, angiography, CT, or no testing. But they don't give you guidance as to which of these is useful. And to be clear, although this is a guideline, it's not based on any evidence. They recommend invasive coronary angiography in patients who have a high clinical suspicion of acute coronary syndrome. And they recommend the use of that tried and tested approach of clinical judgment to guide non-invasive testing. So it's over to you. The more recent US guidance provides a bit more structure around this, but ultimately have very similar advice. They recommend that low-risk patients are eligible for discharge without patient follow-up, but don't guide really who to follow up. Those with intermediate troponin results, they recommend some further testing. And here they suggest the use of risk scores, the modified heart score or EDAX, and to consider non-invasive testing. And they give some guidance on which type of non-invasive test to recommend, whether that's an anatomical or a functional test. But in reality, neither of these guidelines are based on any evidence, and we are just left to clinical judgment when it comes to deciding who to follow up. But having demonstrated that these patients who are discharged have a not insignificant risk of myocardial infarction or cardiac death in the first 12 months, I think it's important that we generate some more evidence for this space. So here's a small observational study from Edinburgh done by my colleague Ken Lee. He took 250 consecutive patients who had myocardial infarction ruled out, and he enriched them for those with intermediate troponin values on a 2-to-1 ratio, and everyone got an outpatient CT coronary angiogram following their discharge. And what this slide shows is that the higher your troponin concentration within the normal reference range, the more likely you are to have underlying coronary heart disease, whether it's obstructive or not. Indeed, 71% of patients with intermediate troponin concentrations had coronary artery disease on a scan. Interestingly, having an intermediate troponin concentration doubled your risk of obstructive disease, tripled your risk of having any coronary artery disease compared to having a value below the rule-out threshold. But if you stratified this according to whether or not the clinician who was assessing the patient thought they had angina, then the hazard ratios are identical, suggesting we are not very good at using the clinical history to select patients for testing. But ultimately, that is what we tend to use using clinical judgment. So I think providing objective information through troponin might add to clinical judgment. And just one other important point, the majority of patients with intermediate troponin concentrations who were found to have coronary artery disease were not known to have coronary disease previously. So this is the identification of new disease, and as a consequence, the majority of these patients were not on what I would describe as optimal secondary prevention with an antiplatelet drug or a statin. So I think there is an opportunity here to identify individuals who we know are at risk of future events, who have underlying coronary disease, and to potentially improve their outcomes purely by guiding the use of secondary prevention. But of course, really to know whether that is something we should recommend routinely in clinical practice, we need to do a randomized trial. And the Target CTCA trial is a randomized open label with blinded endpoint parallel group study that is underway in the UK. And I'm pleased to report, as of last week, we completed enrollment of 3,170 patients in this trial, and they are being randomized to early outpatient CT to guide secondary prevention or standard care to determine whether this approach of using troponin to target cardiac investigation can reduce the risk of subsequent myocardial infarction or cardiovascular death. This trial will report in 2024. So the guidelines mentioned risk scores in this space. Are they helpful to select patients for further cardiac imaging? So here's the truth is there's no data on this as yet, but we do have many risk scores. So this is some examples of risk scores that may be used in your hospital. The heart score and the EDAC score were specifically designed to aid in the rule in or rule out of myocardial infarction, but some of the others were actually designed for different purposes. So TIMI and GRACE are really designed to guide risk in those who have myocardial infarction. And similarly, there are other primary prevention scores that may be helpful here. I just want to show some data just to give you a feeling of what the distribution of risk is in this population from the previous study I showed you by my colleague Ken Lee. So Daniel has been looking at risk scores in this population, and you can see that on heart and TIMI, there's a mixture of what are described as low risk or intermediate risk patients, and there is a reasonable spread of risk within those ruled out. These are some target plots just demonstrating the diagnostic performance of these risk scores in ruling out coronary artery disease. And the first thing you'll note is that none of these scores have a high enough negative predictive value to rule out the presence of coronary disease. They do a little bit better at ruling out obstructive coronary disease. These data are in the top part of the panel. The positive predictive value is low, but they are better than using troponin on their own. So troponin plus a risk score does appear to improve the discrimination for the presence of coronary artery disease, suggesting there may be some merit in using risk information to guide subsequent investigation. So Yara already touched on this next topic, which is, can we combine laboratory data and risk information using statistical modeling to improve our ability to identify those at increased risk in the future. I always worry a little bit about using statistical models in clinical practice, but I'm reassured by this slide, which shows you that risk scores are nothing new, and using computational models to guide treatment has been going on for 3 decades, at least in the city of Dundee. So what about more modern statistical approaches? So this is a study that we worked on together on machine learning, which combines cardiac troponin as a continuous measure along with other laboratory data and risk factors that influence pretest probability and influence troponin values. And we trained this model in 10,000 consecutive patients in Scotland with an average age of 70, half of whom were women. And then we validated it together with colleagues, some of whom are on this webinar, in 7 different countries to determine whether the model was reliable. Now, the primary purpose of the model is to rule in and rule out a heart attack on arrival, and it does that well. But it generates a probability of 0 to 100, and you can see that this is well calibrated across the spectrum of risk seen in these pooled external validation cohorts. And so it does its job well in triaging patients because it incorporates time of symptom onset as well as other features. It is able to discharge more than 60% of patients using a single cardiac troponin value, and up to 72% with second test if required. But it also provides personalized information about future risk. So in those who remain intermediate probability, even using a machine learned algorithm, those probabilities can inform on future risk. One of the other major advantages of using a model is that it allows us to ensure that the performance of troponin is equal for men and women, older people and younger people, those with and without comorbidities. So it helps us to reduce inequalities in care. But these are the 1-year outcomes for cardiac mortality. And if you've got a low probability on this algorithm, then your chance of having a cardiac death at 1 year is 1 in 1,000. And that compares to those with intermediate or high probability scores. So I think in the future, incorporating cardiac troponin together with information about risk and comorbidities is going to give us even better opportunities to select those who would benefit from further investigation. So I'll just sum up here with some concluding points. High-sensitive cardiac troponin is a highly effective approach for risk stratifying patients without myocardial infarction in the emergency department. If your hospital is not using high-sensitive troponin in this way, then they should. Patients with intermediate values may well require further observation in the emergency department, and they may benefit from cardiac imaging, either as an inpatient or an early outpatient. But randomized trials are ongoing to help us determine whether that leads to better longer-term outcomes through the identification of unrecognized, untreated coronary heart disease. And finally, machine learning algorithms or other statistical models that provide decision support in the emergency department could not just help us reduce inequalities and improve triage, but also identify those who are at increased risk of major cardiovascular events over the longer term. So I'll finish just with a quick thank you to my colleagues who helped prepare some of the slides for me today, and I look forward to the discussion. Thank you.
Nick, thank you very much. If you could remove your slides, we'll get Paul's on there. So our committee, the Clinical Applications of Cardiac Biomarkers Committee, is an educational committee. And what I've learned, we'll wait till the questions that are in, I'll wait for Paul's slides to come up here, is that we're looking at virtual vinyl records and we're looking at spider webs almost. So I have some very interesting questions for Nick. But our last speaker today is a clinical, but more importantly, a laboratory colleague, Paul Collinson. I've worked with Paul scary to say, 30 to 40 years. He's a professor of cardiovascular biomarkers presently at St. George's University of London. Paul and I, his careers have somewhat paralleled in the cardiac biomarker world, starting back in the days of CKMB, or even before in total CK. But most importantly, we've been working together at educational modes in our current committee work with the IFCC, which we're very thankful for providing the opportunity today to present. So with that, Paul is going to address single sample rule out of NSTEMI. Are we ready for prime time? And I'm sure there's going to be a strong laboratory component from this. Paul, thank you. And one last comment before Paul starts, since he lagged behind. I encourage all the participants to email or present their questions. So at the end, we're going to look electronically at the questions that have been submitted and address those. Thank you. Paul, sorry to interrupt. Paul, I think you need to turn on your video, okay?
Professor Apple, looks like we've a bandwidth issue there. So what we can do is we can share the slides from the IFCC office. If Professor Collinson could speak over the top of them, would that be okay?
Yeah, okay, that's fine.
That's fine.
I seem to be having some problems here.
Yeah, sure. So if you just say next slide when you want us to advance, and if you just give us a moment to start that process. Thank you very much.
Okay, we everybody see those?
Yeah, that's working
Yes.
well. We can see and hear.
Right, okay. Well, when it comes to the question of implementing rule out and rule in algorithms, what should the laboratory do? Next slide. Well, it's quite easy. We don't have to do anything. All we just have to do is measure the troponin. Can you click next one, please? But unfortunately, it's not that simple. Next. The key points we really need to consider here are the algorithm, the assay, and the analytics. Next. First of all, when you're considering the algorithm and you're going to implement it, it's crucial that you engage everybody who's going to be involved in this for successful implementation. This means discussions involving the emergency department, all the staff, the laboratory, all the staff, and the cardiology, all the staff. This doesn't mean that you discuss it with the head of the laboratory, the head of cardiology, and the head of the emergency department, because if they haven't got good staff engagement to start with, you're not going to get anywhere. Next slide, please. And one of the things that we have recognized in multiple surveys of the use of cardiac guidelines is that failure of laboratories to interact with clinicians in development has been a consistent finding from 2008 through to the last survey in 2021. And this is a real problem, and that clinicians shouldn't be hiding in the lab. They should, lab people shouldn't be hiding in the lab. They should go out and talk to their clinical colleagues. Next, please. And why should they do this? Because of the whole logistics of implementation. We're talking about explanation of staff roles. Are there sufficient staff to support the proposed pathways at all points in the pathway? Are the roles and responsibilities clearly defined? Does everybody own the partnership, own the pathway? Because if you don't have this, you won't get good implementation. You need to manage expectations. It's no good saying to people, you're going to have your results instantly. And if they come back to you and say, I want results in 10 minutes, you say, you want results when? So consider things like feasible turnaround time, and also do a reality check on the proposals. You have to verify if implementation will improve patient flow. After all, It's no good busting a gut to give a turnaround time of 30 minutes when it actually takes 2 hours for the clinician to see the patient. You're not going to get any benefit at all there. Next slide, please. When it comes to the algorithm, you've got to know which algorithm you're dealing with. And remember that basically we've got two sorts. We've got the European Society of Cardiology algorithms, and these are predictive algorithms. They don't actually say whether the patient will or will not have a myocardial infarction. They predict whether they are a high likelihood or a low likelihood or intermediate likelihood. Next slide, please. And as Nick has pointed out, the algorithms require further testing to patients classified as intermediate. And this means you've got to be able to provide the same assay and the same sample matrix, because if you don't have these to calculate the delta, you're not going to actually be providing the same information unless you've already previously validated that different sample types can be used. And all the analysis must be by the same analyzer type, or if you're going to be using point of care testing, you're going to make arrangements to retest the samples by the laboratory or test the follow-up samples by point of care testing in your intermediate group. And this is one of the aspects we highlighted in our recent comment on point of care testing from the IFCC committee. Next slide, please. We also have predictive and diagnostic algorithms in the European Society of Cardiology, which is the 0.3 algorithm using admission rule out. This in fact incorporates both rule out and a 99th percentile both diagnosis. And in the high stakes algorithm that Nick ably illustrated, shows the something appears to have popped up on my screen here. Shows the how you can actually mix the combination of rule out and rule in and follow up intermediary. Next slide, please. And of course, the choice of algorithm will define the logistics that you use. If you're going to use a Norton 1 hour algorithm, that means that it's obligatory on you to provide a 45-minute brain-to-brain result. That means that after the patient comes in for their initial sample, there's got to be a result in front of the clinician within 45 minutes. Otherwise, they are not going to be able to make a decision to discharge the patient. Now, the ESC, if you look at the 0-1 algorithm, recommends taking the 1 hour sampling and sending it to the lab. I'm afraid to say that human nature and clinical risk management means that clinicians will wait for the second sample result. This means that the utility of the single sample rule out has been largely destroyed. And it is my personal belief that you should use an algorithm that matches your turnaround time if you want successful implementation. That means using either a 0-2 or a 0-3 hour algorithm. Next slide, please. Are there going to be benefits from implementing these rapid diagnostic algorithms? Well, there's evidence from clinical trials that shows a reduction in length of stay, and a study which compared routine care based on the conventional pathway shows the benefits that could have been achieved by implementing the ESC guide algorithm. And finally, economic modeling suggests that there would be a significant benefit from this type of approach. Next slide, please. What about real life experience? Sadly, in reality, the majority of troponin testing does not follow pathways, but is single sample testing without follow-up. I recommend this study in European Heart Journal because it shows you that, in fact, as many people will attest, something like 70% of the troponin testing is an algorithm-based, and you need a regular audit cycle. Next slide, please. Does your assay have an evidence base that shows it can be used for single sample rule out? And does published data match your disease prevalence? The negative predictive value of a test is strongly affected by a prior probability of disease. Next slide, please. This is just a interesting little plot showing the prevalence of disease versus the negative predictive value. And I've looked here at sensitivities of 99, 98, 97%. And as you can see, 97% works beautifully, providing your prevalence of MI is 15% or less. But interestingly enough, once you get down to a prevalence of MI of 1%, diagnostic sensitivity only has to be 50% for your test to work perfectly and have a 99.5% negative predictive value. So be very careful here. Next slide, please. So local studies may be required to assess transferability to the local population. Analytics. What about assay performance, analytical technology, and quality assurance? Next slide, please. These are the assay performance and precision goals calculated for a set of thresholds for rule in and for rule out, I beg your pardon. And if we take a rule out threshold of 1, you can see that basically this can round up to 1.5, and this gives you an imprecision of 25.5% as your precision goal. In other words, you've got to have less than that. If we take a value of 2, however, this may round down to 1.4 and get inappropriate rule out, which has got a CV of 15.3. Next, please. So that's the imprecision goals for achieving safe rule out. And next. What about analytical technology? Well, in a multi-user multi-analyzer system, the imprecision is going to be affected by which analyzer, which cell, and this is most marked when you get repeat sampling. But imprecision and assay performance may differ between different models of the same system. For example, we found 2 different models of the Roche system showed markedly different imprecision in routine clinical use. And this again may affect whether you can achieve these imprecision goals. Next slide, please. Finally, quality assurance. Quality controls need to be selected to match the decision thresholds used in order to monitor performance. And current commercial QA material does not address this. An in-house QA may be required. If you're like as old as Fred and I, then you'll go back to the good old days when we used to make sample pools and put them in the freezer and then use them over the course of the next few months. Next slide, please. So what about the future? Well, it's been alluded to. Will we use point of care to address the turnaround time issue? But this again will fail unless the whole process of clinical decision making is addressed. Next slide, please. So I always like to finish up with a shark for my fans out there who know that I take pictures of sharks. And this is just a baby shark. Thank you very much indeed for your attention.
Paul, thank you very much. I think at this time we'll get all the speakers on. Again, I encourage the audience to submit questions they may have. I will say that as we're waiting for Paul to get on. Paul, are you on? And Yader?
For some reason, it doesn't want to play.
You can't get a video on there, and I will wait for Yader. But
yes, no, I'm here. I'm here live.
Okay, so I think I'll start with questions both from the audience and myself. But the first question I'm going to ask the panel has to do with a point of care testing. I mean, there are a couple assays out in the world that are designated appropriately for high sensitivity cardiac troponin testing, troponin I in Europe and that are approved, and actually troponin T in China. But the question I have is, and I'll start with the clinicians, Yader, Professor Sandoval, and Professor Mills. Let's say I bring in this high sensitivity point of care test into my emergency department. Yet my central lab has a different assay, therefore different numbers. The question I have is, do you think can you recommend it as acceptable or not that I just bring it, if you have trouble with the turnaround time, because Paul talked about turnaround time, can I just bring a high sensitivity point of care assay in? Maybe it's an 8-10 minute assay, and just use it for ruling out individuals or selectively admitting patients, and then transfer the rest of the testing to the central lab. So Nick, let's start with you on that one.
Yeah, it's a good question, Fred, and I think a lot of people are grappling with it. I think Paul made the point that when implementing pathways, it's really important to have all the stakeholders involved. And I think if you're going to use 2 troponin assays, it's doubly important. My feeling is that point of care will accelerate triage and will find a role in emergency departments. And it will allow us to make decisions within an hour very, very efficiently. But if we are going to consider admission or further testing, it will need a core lab test sent as well. So for that single test rule out population, you may not need any verification with the core lab. You may be confident enough to rule them out. But if they're not ruled out, then and you are considering admission, I think you're going to end up sending a core lab test because the rest of the hospital probably use the core lab test. And ultimately, we need to separate out what these point of care tests do, which is triage, from what we do when a patient comes into hospital to make a final diagnosis. And the final diagnosis is probably going to be predicated on the 99th centile of the core lab result. And that's probably how I would try and operationalize it. But I would say we're still evaluating point of care locally. We haven't tried to implement it in parallel at this stage. And that's just my thinking at this point in time. But I'd be interested in other views because it's not straightforward.
Yader, as a clinician, can you comment on that?
Yes, it's actually a very timely topic to our recent implementation. As alluded earlier, I transitioned to a recent healthcare system that we just made the transition from a contemporary AVID to a high sensitivity T early this year. And prior to that, a lot of the emergency physicians were using point of care. Long story short, I do think there's a tremendous value for point of care for several reasons. One is, for example, many of us practice at the tertiary quaternary care main hospitals that have all the tools and gadgets. But for example, our system is a large multi-center healthcare system with smaller urgent cares, smaller systems that do not have, space or sophistication for laboratory-based instruments. And therefore, if you say, well, please do so-and-so algorithm or some sort of a sophisticated AI or something, like this means sometimes getting on a chopper, on an ambulance for 2 to 3 hours to go to a center that has all these tools. So I do think that there's a tremendous opportunity to have a point of care at the location to provide the care pretty much at the point of care as the assay is. I think it's really tremendously valuable. And I think even if the assay were different, let's say we were using a T and there was an I, or there was an I and there was a T, irrespective of the assay, I think it would be considered in healthcare systems such as ours, given it does mean that sometimes patients need to be transferred long distances to get answers.
Paul, do you want to make a comment, or should I move on to the next question?
I think I agree with everything that's said. I think the potential is there, but as I said, you've got to make sure that you're consistent what you're doing. So same sample, same matrix, and how as it goes.
So I'll just add one thing to what everyone said. Is one of the questions from the audience actually had a question regarding the concept of what if you have a central lab cardiac troponin T, high sensitive cardiac troponin T assay, but your point of care is the high sensitive troponin I. Is that acceptable? And I'll comment on it to see if anyone else wants to, but personally, I think the future will be if you're not meeting a good turnaround time in your central lab, independent if it's high sensitivity troponin T or high sensitive troponin I, if you do have that point of care assay, using it just as an early single sample or even a 0102 sample decision maker in the emergency department, I think you'll be okay with that. Because if the patient is admitted, and I think one of the speakers addressed this, once the patient is admitted, you often may want to repeat those early 0 hour or 1 or 2 hour samples. So you'll be able to look at a comparable number as the patient has additional troponins measured in the central lab. Would anyone else like to comment on that?
I'll comment on it. I mean, I would be interested in two things, and one is that people are not meeting the turnaround times, and we've had some of these issues, discussed at our centers. While I do agree that there's opportunities for point of care, as I just addressed in the previous question, I think that people should look at processes first and not cut corners and say, just because I cannot meet my turnaround time, I'm going to use the point of care. So I think first we'd have to look at all the systematic process, as you and I have discussed before, about whether there are any other things that could be improved to really meet that metric before getting a little bit more messier field by having multiple results that are going to really potentially confuse clinicians. But the question that I would bring back to the group related to that is that while I do think there's a lot of promise to point of care assays, assuming all the analytics are correct and these results are reliable, is what level of evidence do we need to adopt this? Like for the high sensitivity laboratory-based instruments, we have meta-analysis of multi-center studies, over 10,000, 20 patients. We have trials like the work that Nick is doing with trials of over 30,000 patients and so on. Would a more modest site observational study of a point of care assay be sufficient to say, let's go live? Are we ready for prime time? To me, that's a real question of this webinar, for example, for point of care. Or do we need the randomized trials for us to implement this, as we've done with laboratory-based instruments?
Can I come in on that, Fred?
Yes, please.
I find my technology appears to be working here. I think the answer is it's going to be a bit of both. I think that it's going to be a two-phase process. The first is to prove that the technology works, and secondly, define what the thresholds ought to be. And once that's been done, I think that the gold standard is to do a randomized controlled trial. I think that's ultimately where we're going to have to end up. I think we're familiar with the concept, and I think if it can be shown that you can get exactly the same outcomes, then I think I would be comfortable to do a controlled trial at that point, but not before. But I mean, to be fair, it takes a long time to get these trials out there, and we've only really got a good randomized controlled trial for the Abbott troponin I, and that's the one that Nick did. I'm sorry to say, I don't think the randomized controlled trial they did for cardiac troponin T in Australia was actually comparing like with like, because they didn't use the accepted 99th percentile. They used they basically said, well, we're not going to report anything below 30, and I think that's why they ended up with the funny long-term results they did. So my bottom line is, I want a randomized trial, please.
Okay, Nick, you have anything to add? Can I move on?
Yeah, I want to come in if that's okay. I think it's a very interesting question. I think we need more data to be confident about the performance of these tests to rule out with the same level of safety we have from core lab tests. And I think observational data, if done well at a sufficient scale, will be sufficient to implement. But I think if we're going to convince healthcare systems that they want to be running two tests in parallel and the costs associated with that, we're going to need randomized trial to demonstrate that it has an impact on healthcare systems over and above the kind of observational data. So I do think randomized trials are going to be necessary to make the case. But my dream, if I could have it, right, is that the patient comes into the ER at the same time as they get their 12-lead ECG, they have a capillary point of care troponin. So I get both results within 6 minutes of arrival. I can decide if they need to come into hospital for further investigation. And at that point, we can use a core lab because they're already coming in and the point of care isn't going to add a huge amount of value. But that initial triage step could be done so quickly, so effectively. And I think that's where the role, even before you have access and venous blood drawn for point of care testing, is really exciting.
Thanks, Nick. I think Paul and I need to have a sit down with you to explain to you some of the idealistic concerns we have for the capillary testing in the world. But I think we all ideally would love to have that, but that's, I think, a little ways off. And I'll just, for a little difference of tone as moderator, I think we're going to see implementation of these high sensitivity assays before we see the results of a randomized controlled trial. as more data comes out just from 1 or 2 studies. Because in reality, we've been using high sensitivity troponin in the central lab without randomized controlled trials very successfully. And there's no reason why a derived and validated point of care assay will not also be successful in the same concept. Which leads into I think another interesting question along these lines. One of our audience speakers asked the concept, first he used the word, or she used the word, ultra-sensitive troponin. And I think the world globally has accepted these assays as high sensitivity. So I think it's best we all use the same terminology. But the question was, can we or should we be using these tests in the outpatient clinics and patients who may be presenting with symptoms suggestive of? Should these be allowed, not just in a hospital, but should we be doing it in outpatient settings? And I'm going to turn to the clinicians first. Anyone want to speak up? Let's start with Nick.
Yeah, I absolutely think there will be value here. It's quite a step, though, currently, and we don't have evidence to support it. So I think it has to be done in the context of a research setting, first of all. For me, new onset angina is part and parcel of the acute coronary syndrome, and troponin will inevitably provide some insights into how high risk or low risk that patient is. But until we've done the research, understood what the impact that might be on patient flow and care, I don't think we're quite ready to recommend it in the outpatient setting.
Paul?
I think it really depends what you define as outpatient. And Yada hinted or mentioned it en passant, where you've got a rural healthcare system where the first port of call is the patient is there, having a point of care high sensitivity method there that actually decides whether you get on the helicopter or in Norway get the boat across the fjord is quite profound. And in fact, there's been quite an interesting study published in Norway where apparently they have an interesting setup where you go and see your primary care physician before they send you to hospital if you're out in the rural area, where they were able to show that, in fact, if this was using a lab system, so it's basically a retrospective study, that they could early identify and safely rule out people who didn't need to go further. And of course, under those circumstances, your prior probability of disease is actually very low indeed. You're talking about the 2 to 5%. So this sort of system would work very well indeed under those circumstances.
Yader, any comment?
Yeah, I think there's 2 parts to that question in my mind. Can we use cardiac troponin in the outpatient office setting? The answer to me, it's absolutely yes, and we're already doing it in many settings, right? You think about cardio-oncology, you think about preoperative assessments, you think even about people that are using this for primary prevention risk stratification, the list goes on. We're already using cardiac troponin in the ambulatory office-based setting for numerous indications in real-life care. So the answer to that is yes. Should it be used in patients with symptoms suspicious for ACS? At least, I think that particularly in very litigious systems such as the U.S., where we're really grappling with these questions and safety is paramount as anywhere. I think that if you're concerning about ACS, those patients are best served in some sort of urgent emergency setting where you have the systems to do an EKG, where you have the systems to potentially do serial testing. You would want to caution not to just do a blood test, not do anything else, and send the patient home without realizing that maybe there were dynamic ECG changes or an intermediate concentration, as Nick alluded, that maybe was rising that was not captured. So I would be very careful and actually do not advise to evaluate ACS patients in the outpatient setting. They should go to a ED-based setting. Those things may change with more data, but I think that at this particular point they're best served in the ED. But for office-based setting for numerous other indications, I think it's totally fair game.
Thank you. The next question I have is, I'm going to just direct this at Paul to start, probably just to Paul. The audience question has to do with what shift should we have in quality control testing using a high sensitivity assay versus those who are just maybe transitioning or even transitioned to central lab or it doesn't matter, point of care testing. Tell us about what kind of quality control materials should we be using and at what levels?
But I think that was actually quite well addressed in the joint IFCC AACC whatever it is AACC is now document when they're talking about what values you should aim at. I think basically you want to be aiming at one that's 1 or 2 nanograms above your rule out threshold, and one that's probably around the 99th percentile, because that will actually get your imprecision at what I consider to be the relevant values. I'm not so bothered about the imprecision at the rule-in point, because by that point most of the assays are really performing quite well. The real problem we've got there is, in fact, that the QC materials which are currently available commercially don't really address those levels at all. So that's why I commented, we're back to the good old days where we used to make up our own pools at the right level and then stick them in a freezer, which I don't think is particularly problematic beyond the obvious about what you get infected with. But I'm slightly cynical about that. When it comes to point of care, I think it gets a little more interesting, because I think when you come to point of care instruments, they're already quite well designed to monitor themselves. And what you really want to do is quality control your batch of reagents, which means I think you quality control it when you get it, and you periodically quality control it. And how frequently you should do that, I think, is a matter of debate. Personally, I don't think you need to do it very frequently, because what you want to make sure is that just your batch of reagents is not going off, because they have internal quality controls as well as electronic testing. Do you think that answers the question, Fred? And have you got any more to add, since you're also a lab rat?
No, I think you did a good job. I think the key here is the answer is yes. We need to make sure we monitor quality control materials that are, in my opinion, especially if you're using sex-specific URLs, reference, one about the sex-specific URL of the female cutoff and one around the male. So we can make sure, especially, ideally, we would have a QC material down close to the threshold we're here talking about today, the single sample rule out. As a matter of fact, our committee, the Clinical Applications of Cardiac Biomarkers Committee is looking to address, we're actually drafting a document right now to address the concept of what would be acceptable variation by even manufacturers that would have variability and lot-to-lot variances as far as the concentration differences. And I think expert opinion at present is a number around 3 nanograms per liter around that before we start possibly seeing misclassification. But I think that data will soon be submitted. There is a lot of data out there, and I'll point towards one author, Pete Kavsak from Canada, has published a great deal in this area. And if you wanted to read his papers, I think it would be very useful. Sometimes confusing, but very useful. Okay, moving on. We only have about 7 more minutes left. I'm going to point this question to Nick to start, and Yadar can kick in if he wants. It's a colleague from Spain, from Madrid, wanted to as some advice. If we're going to bring in our own algorithm, if we're going to bring in a high sensitivity, which we already have a high sensitivity assay, but we're going to start using a algorithm-based single sample or 2 sample rule in, rule out concept, should I have to validate my own population and establish my own cutoff, or can I base it on what I have observed and read in the peer-reviewed literature?
Good question. I think the short answer is you should rely on the published literature for the specific assay that you use, because to define an optimized rule-out threshold needs tens of thousands of patients to do it accurately and precisely. And I don't think that's something that you can just do locally without significant initiative and effort and time. But if the assay you're using doesn't have good published data, then you may have to develop your own approach. But I think if that were the case, you would use the most conservative approach, which would be the limit of detection, until you had greater confidence in the assay. But most of the available commercial assays have have got some research data to support validated rule-out pathways.
Thank you. Yadar, I know Yadar has a question he'd like to ask. Yadar?
Yeah, to that question, the first one you asked, I will say that I think it's fair game as long as you have robust peer-reviewed literature that you think it's reliable to adopt into clinical care. Our system, or the previous system that I was at, we used 6 specific 99 percentiles from the literature independent from the manufacturer that we evaluated comprehensively in a multidisciplinary team, lab, ED, cardiologist, and we said we're going to use the sex specific 99 percentiles, which are not the one for the manufacturers, but it's a careful decision. Yeah, I wanted to ask a quick. I think we're all clearly share that this is safe, the single sample rule out, particularly for rule out MI. But I think Nick's talk was very interesting and brings to point some issues that I think are merit a little bit more discussion. I think it's very safe that we say if your fat value is very low, you have a non-ischemic ECG, your likelihood for having MI or death is excellent. I think that's almost at this point not unquestionable. But this issue of obstructive coronary artery disease that you address, I think it's very important. As a clinician, I can tell you that I deal with this regularly, and in which you have patients that have some angina symptoms. Sometimes they can have samples below the limit of quantitation, that is the lowest that we can see. They do not meet the MI definition. They have a non-ischemic ECG. You cath them, they have horrible coronary artery disease. Yeah. And then people start questioning, well, see, that assay didn't work as well as you were alluding to. Look at this horrible coronary artery disease. So I'm interested in your take on how to integrate that, particularly since you're looking at this with CT, because at least from our perspective for the audience, it's important to really underscore to the audience that we're talking about safely excluding myocardial infarction. This is not for unstable angina A, and B, people can still have severe coronary artery disease. So if you're concerned about the symptoms, patients should still be evaluated. So I'm interested in your take based on all that data you showed about coronary artery disease.
And Nick, just to let you know, I need to keep you to 2 minutes, because we have 4 minutes before we have to sign off.
All right, I'll try and keep it short. So absolutely, troponin cannot exclude the presence of underlying stable obstructive coronary disease. What it does tell you a little bit is about your risk of events, and half of the population at the age of 60 are walking around with coronary disease. They're not all dropping dead of a heart attack. So what it tells you is that you can afford to relax and manage their symptoms or investigate their symptoms as an outpatient, because the risk of something acute happening that might make them unwell is extremely low based on the troponin. But if they've got good history of angina and they've got risk factors, you may well want to follow up in the outpatient clinic and investigate them further. But I guess what I'm saying is, if you wanted to investigate systematically your population of patients whom heart attack is ruled out, then you would pick up a higher yield of coronary disease and people that would benefit from treatment if you focus on those who've got intermediate troponin values, because they are a high-risk group of events, not necessarily a high-risk group of having just unstable angina. Does that answer the question a little?
Yeah. I think it's a point worth emphasizing. Thank you.
Can I just make one point though, Fred, coming back to the original question? I think that one can rely on the peer-reviewed literature, but you have to make sure that the prevalence of disease in the cohort, which the derivation was, is either similar to or higher than your own, because that's the only area that you just need to be careful about. Because if they do it in a cohort that's got a really low prevalence and yours is much higher, it's not transferable.
Thanks, Paul. And my prerogative to have the last word on just to answer another question that came up before I read my concluding comments, is the question came up from 2 or 3 people. When we do implement the 0, 1, 0, 2 algorithm, or even the baseline algorithm, a single sample algorithm, and the symptom onset is very early to time to presentation, how do they work? And I think we've heard other people say this in this talk, but look at the papers. Is typically, if you're an early presenter, which you're defined often as 2 hours or less, the sensitivity and sometimes the negative predictive values do not work as well. So you have to keep in mind that early presenters may not fit into the same success rate. It might be minimal as the later presenters after 2 hours. Nick, did I say anything wrong there?
No, that's spot on. I think those patients, until we have an alternative, require a second test and some observation. But I do think it's interesting that the machine learning algorithms that incorporate that in might be able to be even more flexible, because they can use even lower values than the rule out threshold, combined with symptom onset, to potentially even send some of those patients home confidently.
And on that note, I'll just comment, we didn't get a chance, there were several questions on the machine learning concept, which we didn't get a chance to because of time, but the one thing that we will wait on is all these, there's now there's actually at least 3 different machine learning papers out there on individualized, personalized predictability and probability of having an MI or not. But we haven't seen a head-to-head comparison, unless I missed it, to the current practice we are using, the single sample or the 0, 1, 0, 2 hours that are recommended, like the ESC. So I look forward to seeing that. On that note, let me conclude. First, I want to thank all our speakers. I think this was an excellent session, very high level at some points and moderate to low level at others. Dr. Sandoval, Professor Mills, Professor Collinson, thank you for your presentations on this topic. And clearly, my thanks go out to Dr. Hamilton for coordinating this webinar, IFCC, for offering this learning tool, and behind the scenes, what it takes as a learning tool for our e-learning programs at the IFCC. There is a certificate of participation that will be provided at the end of the webinar after addressing a few questions. At the end of the questions, please click Show My Scores at the end of the page and get your certificate. In addition to the actual webinar, IFCC is pleased to announce that it's making these courses available to all the participants on cardiovascular topics. As a matter of fact, this will be posted both on the IFCC website, and this will be also posted on the Committee of Clinical Applications of Cardiac Biomarkers. These courses are based on the concept of adaptive learning. We've learned this is very successful since COVID has happened. The IFCC has been a leader in this. They can help you to assess your knowledge in this important area of research and maintain competency in it. And please register on the site. You'll find a link among these to the resources of this webinar, and it is free to do this and use this. And last, the on-demand content of this webinar will be available in short time period, and you will be informed of this in email. And there will soon be other free IFCC webinars, both in our cardiovascular. I think we have, in our committee, has at least 2 more planned this year, and in other areas, in laboratory medicine and just medicine and different forms of medicine. And they will be announced in IFCC communications on email and website and social media. And with that, I'd like to thank everyone, again, especially the speakers, but more importantly, the IFCC for their support and the people behind the scenes at the IFCC that make this happen. And with that, we'll sign off, and I'll say, everyone have a great day. And if you're going to Rome, which I will be going to, we hope if you run into any of us, please say hello for those of us who are there. And if the questions were not answered, we will get those and try to answer them through an email. So for now, have a great day. Thank you.
Thank you.